Okay, I'll try and stick to the 5 minutes. So we'll talk through my perspective on it, and the key things I'll focus on today are why do we focus on hypoglycemia in the first instance? Because we know tight glycemic targets are central in having good pregnancy outcomes. We know severe hypoglycemia is more common in early pregnancy than any other stage in a woman's life that has type 1 diabetes, and also because maternal hypoglycemia has got immediate maternal risk as well as plausible fetal implications. The pregnancy physiology is very unique. So firstly, what happens in pregnancy, in early pregnancy, is there's increased insulin sensitivity and there's reduced hepatic glucose production. There's continuous placental glucose transfer, which leads to maternal glucose levels falling rapidly during early pregnancy, especially during fasting. And there's altered counterregulation, which leads to a blunted glucagon response and reduced adrenergic warning symptoms. Type 1 diabetes amplifies this the risk, and that is because of the defective glucagon as well as the pregnancy physiology together, which is why there is such high glycemic vulnerability in these patients. If we look at this graph here, the physiologic trajectory of insulin sensitivity across pregnancy varies. If you look at the green line, in early gestation, there is increased insulin sensitivity, and that peaks at around 15 weeks of gestation, and that is why often we tend to see women with type 1 diabetes having more frequent hypoglycemia in first trimester, secondary to that occurring. As the placental hormones rise throughout the pregnancy, insulin resistance increases, and the exogenous insulin requirement also climbs. Understanding this curve is really important because it helps us elaborate more on the pattern of hypoglycemia versus hyperglycemia as is clinically. And trying to discuss this with patients is extremely important. Now, the causes of hypoglycemia can vary. We already know that at-risk cohorts include patients with type 1 diabetes, patients that have had bariatric surgery. I wouldn't do an oral glucose tolerance test in these patients, but sometimes it does happen, and they often can have what we call late dumping, where they have quite significant hypoglycemia at 1 or 2 hours. Patients that have hyperemesis or adrenal insufficiency, and very rarely they may have undiagnosed insulinomas. The clinical associations with hypoglycemia include having placental insufficiency, intrauterine growth restriction, abnormal umbilical artery Dopplers, oligohydramnios, and increased risk of preterm delivery. And so while we often focus on hyperglycemia, we do overlook the fact that hypoglycemia can have its own array of complications that we need to try and address. Gestational diabetes and treatment-related hypoglycemia is also important to consider. It's not rare to have hypoglycemia in GDM, and there are some studies that have associated hypoglycemia in mothers with NICU admission or composite neonatal morbidity. But the critical question in these scenarios, given the limited data, is the hypoglycemia causal, or is it a marker of aggressive treatment and disease severity? And that's a question that we still need to explore with further research. We mentioned briefly during OGTT, if there is hypoglycemia, is it noise or is it a signal? Now, there's very small or limited evidence around this as well. Some studies show that there may not be any significant adverse outcomes in patients that have hypoglycemia in an OGTT, whereas others, there are some suggestions of increased rates of SGA, macrosomia, or NICU admission. The possible explanations for patients having hypoglycemia at 1 or 2 hours on their OGTT is they may have a relative hyperinsulinemia, they may have evidence of early beta cell dysregulation, or there may be some ethnic or metabolic phenotype differences that account for that occurring. So it is important for us to use our clinical judgment to try and determine which of these may be relevant for our patients. When it comes to monitoring and management, we have to try and go beyond the algorithms. And the reason why is because no two patients are going to be the same. One patient may have a whole pizza and not have a high glucose level. Another patient may have a bread sitting nearby and have hypoglycemia. So you have to focus on isolated patterns rather than a generic approach towards these patients. It's important to try and prevent overcorrection of the postprandial, and interpretation of the OGTT hypoglycemia depends on their clinical context. For example, as I mentioned, if they've had bariatric surgery previously. And guidelines are just that. They're guides, so they don't have to be taken as gospel. If you feel that your clinical judgment suggests that you should do something differently in that particular patient, then that would be what I would go with instead. There are research gaps. We need to individualize glycemic targets, what the thresholds are for different patients. Is recurrent mild hypoglycemia significant or not? And can CGM be utilized a bit more in pregnancies to try and help diagnose patients more effectively, as well as what the different characteristics of patients have in terms of impact on their glucose levels, such as BMI. So overall, to summarize, hypoglycemia in pregnancy is common, it is complex, and it's under-examined. Phenotype does matter because not all hypoglycemia is the same, and management requires expert clinical judgment and not just looking at targets specifically. Thank you.
Thank you. Thank you, Dr.